بسم الله الرحمن الرحيم. اسمي أحمد الهواري، أستاذ جراحة العظام في جامعة المنصورة, and today I'm going to talk about the injuries of the foot and the ankle. First, we will talk about the bony anatomy of the foot and the ankle. In foot and ankle, there is the tibia and the fibula. Beneath the tibia is the talus, and beneath the talus is the calcaneus. In front of the talus is the navicular bone, and in front of the calcaneus is the cuboid bone. In front of the navicular and the cuboid there are 3 cuneiforms, then 5 metatarsals and phalanges. Then we will talk about the muscular anatomy of the foot and the ankle. Anyhow, the muscles are arranged into 2 groups, one anterior and one posterior. Generally speaking, any muscle occurring in the anterior group, when it contracts, it will cause dorsiflexion of the ankle joint, while any muscle in the posterior group, when it contracts, it will cause plantar flexion of the ankle joint. Being in the anterior group and in the medial side, so when it contracts, it will cause dorsiflexion and inversion like the tibialis anterior muscle, and vice versa. If it's present in the lateral side, it will cause eversion. Being in the posterior group and in the medial side like tibialis posterior muscle, when it contracts, it will cause plantar flexion and inversion. One important thing that you should know about the foot and the ankle is the presence of the arch. There is medial longitudinal arch, which is under the calcaneus, the spring ligament, the navicular, the cuneiform, and the first metatarsal. There is another lateral longitudinal arch, which is under the calcaneus, the cuboid, and fifth metatarsal, and there is transverse arch beneath the head of the 5 metatarsals. The joints of the foot and the ankle. First, we'll talk about the ankle joint itself, which is responsible for the movement or dorsiflexion, plantar flexion of the ankle joint. But dorsiflexion is usually associated with eversion and external rotation, while in plantar flexion it's associated with internal rotation and inversion. Beneath the ankle joint is the subtalar joint between the talus and the calcaneus, combined with the super joint or 2 famous joints. One in the lateral side which is called the calcaneocuboid, and one in the medial side which is called the talonavicular joint. These 3 joints is responsible for eversion and inversion. This is the axis of movement of the subtalar joint while doing eversion and inversion. The ligamentous anatomy. There are 3 main ligaments of the foot and the ankle, one in the medial side which is called the medial ligament, one in the lateral side which is called the lateral ligament, and between the tibia and fibula is the syndesmotic ligament. For the deltoid ligament is formed of the superficial group and the deep component. The superficial component is the tibiocalcaneal ligament and tibionavicular ligament, and the deep component is the posterior tibiotalar ligament and the anterior tibiotalar ligament. The anatomy of the lateral ligament. The lateral ligament is composed of 3 different ligaments, one in the anterior and one in the posterior, which is called the anterior talofibular ligament and posterior talofibular ligament, and between the fibula and the calcaneus is the calcaneofibular ligament. For the syndesmotic ligament, which is responsible to keep the fibula beside the tibia to close the ankle mots, this is called the syndesmotic ligament, which is formed of the anterior and posterior inferior tibiofibular ligament, and in between is the interosseous ligament. The inversion ankle sprain is more common than the 2 other ankle sprains. Usually the anterior talofibular ligament is disrupted, which is the weakest of the 3 ligaments. Mechanism of injury, usually due to rolling of the ankle, like landing on another athletic foot or stepping in a hole. The inversion mechanism can result in ligamentous injury or bony injury. The structure which is usually injured is avulsion fracture of the lateral malleolus, avulsion of the base of the fifth metatarsal, and push-off fracture of the medial malleolus. You can easily diagnose the presence of lateral ligament injury by presence of dysecchymosis at the lateral side of the foot due to injury of the vessels inside the anterior talofibular ligament. The first aid management is usually RICE, rest, ice, grip bandage, and elevation. This is a cadaver dissection to show the exact anatomy of the ankle joint, which is the medial ligament, the lateral ligament, the tibiofibular ligament. This is the anterior talofibular ligament. From the lateral side, you can see the calcaneofibular, the anterior talofibular ligament, and this is the anterior inferior tibiofibular ligament. Usually the treatment of the lateral ligament injury is conservative, but if the patient continue to complain from the lateral ligament instability, so you have to do something for this patient, and in such case we do suturing of the anterior talofibular and the calcaneofibular ligament, but it becomes weak, so we have to augment such repair by doing reattachment of the extensor retinaculum to the anterior part of the fibula to augment our repair. The main problem of the lateral ligament injury or the lateral ligament instability is the proper diagnosis, because it's commonly to be missed with other injuries. In inversion injury, there may be hitting of the dome of the talus to the medial side of the tibia, resulting in what is called OCD or osteochondral defect or osteochondral injury, which can easily be missed in the first X-ray. Sometimes the lateral ligament is misdiagnosed with posterolateral process fracture of the talus or anterior process of the calcaneal fracture. The second most common injury in the foot and the ankle is the metatarsal fracture, and in the top is the base of the fifth metatarsal. Usually the mechanism of injury is direct force or twisting or torsion force or sometimes overuse. The most common injury in the base of the fifth metatarsal, because it can occur in 3 zones, is the Jones fracture. Usually it results from inversion injury, so the pull-out of the peroneus tendon may catch part of the base of the fifth metatarsal, resulting in fracture of the base of the fifth metatarsal, and the diagnosis is very easy by localized tenderness and localized edema over the base of the fifth metatarsal. The first aid is usually RICE, rest, ice, grip bandage, and elevation. And finally, you can do below knee cast for about 1.5 months or 6 weeks duration. For the eversion ankle sprain is less common than inversion ankle sprain, usually result in deltoid ligament injury, but it's usually associated with bony fracture. This cadaveric dissection to show the anatomy of the medial ligament, which appears well from this photo. It can result in avulsion fracture of the medial malleolus, contusion of the deltoid ligament, which becomes entrapped between the medial malleolus and the calcaneus, and sometimes is associated with fracture of the lateral malleolus. The third ankle sprain is the high ankle sprain, or the other name is the syndesmotic injury. This cadaveric dissection shows the presence of a ligament between the tibia and fibula to keep it aside, which is called the anterior tibiofibular ligament. The mechanism of injury is forced dorsiflexion or extreme plantar flexion and inversion. Sometimes it can occur from landing on the back of the leg with the foot in contact with the ground. The manifestation is usually a swelling, but sometimes is not present, pain, localized tenderness, and inability to bear weight. The treatment first is rise, rest, ice, grip bandage, and elevation. And if you have injury in the syndesmosis, you have to do reduction and fixation by syndesmotic screw or tight rope, or a combination of syndesmotic screw and tight rope. This is a screwdriver of the tight rope. Ankle fracture and ankle fracture dislocation. This is very common injury in the foot and ankle. And the mechanism of injury is similar to those of ankle sprain but of higher velocity. It can occur and result in open fracture or closed reduction. You have to notice the position of the foot during this injury, and you have to examine the patient early before edema occurs. Again, you can find it open. This is open fracture dislocation of the ankle joint. And you can classify the open fracture of the ankle joint according to Gastello and Anderson classification, which classified generally the open fracture into type 1, which is wound less than 1 centimeters, type 2 with wound between 1 and 10 centimeters, type 3, and type 3 is subclassified into type 3A, B, and C. Type 3A is minimal preosteal stripping, while in type 3B is significant preosteal stripping, while type 3C there is presence of associated neurovascular injury. This is an example for the ankle fracture dislocation, and you can notice the adduction injury or the vertical fracture line separating the medial malleus, transverse fracture of the lateral malleus with ankle dislocation. Generally, the ankle joint looks like a ring, so you can notice the presence of the tibia, and connecting to the tibia is the medial ligament, and the medial ligament is connected to the talus, and after the talus is the lateral ligament, and which connects the talus to the fibula, and the fibula is connected to the tibia through the syndesmotic ligament, so it is a closed ring. When it becomes injured in one side, so there is fenestration of the ring is still stable, and you can manage such fracture by doing below knee cast. When it becomes injured in two sides, like in the syndesmotic injury and fracture of the medial malleus, so the ring it becomes two parts, which is unstable, and you have to do something for this patient, and you have to do open reduction and internal fixation. Generally, the Boots fracture or malleolar fracture is classified according to Dennis-Wipper classification, which classifies the injury according to the level of the fracture of the lateral malleolus, below or infrasyndesmotic, syndesmotic, and suprasyndesmotic injury. Another famous classification that classified the malleolar fracture according to the mechanism of injury. First is the supination external rotation injury. You can see the fracture of the lateral malleolus. You can see the injury of the medial ligament or the fracture of the medial malleolus. Supination adduction injury, you can easily see the vertical fracture, which is a spiral or vertical fracture of the medial malleolus with transverse malleolar fracture of the lateral malleolus. This managed through anteromedial approach, but you have to do anti-gliding plate, and you have to see the comminution and its effect in the articular surface of the tibia. Pronation external rotation injury. There is avulsion fracture of the medial malleolus or deltoid ligament injury. There is high up fracture of the lateral malleolus with associated syndesmotic injury, which is very common. So you have to do fixation of the lateral malleolus using plate and screws, and we have to do reduction of the syndesmotic injury and doing fixation using syndesmotic screws. Pronation abduction injury. There is fracture or oblique fracture of the medial malleolus with impaction or comminuted fracture of the lateral malleolus. So you have to do open reduction internal fixation for the fibular fracture and malleolar screws for the medial malleolar fracture. Sometimes there is associated fracture of the articular surface of the lateral part of the tibia, which is called tilo fracture, and you have to do reduction, open reduction, internal fixation for such fracture. The posterior malleolar fracture. The posterior malleolus is very important for the ankle stability, for being attached to the posterior inferior tibiofibular ligament. The fracture pattern is usually variable, which is difficult to be assessed using the standard lateral radiograph. So you have to do CT scan to measure the actual side of the posterior malleolus. And generally speaking, if it's above 25% of the joint surface, you have to fix it. Problem in assessing the fracture size can be managed easily if you do CT scan. So in the CT scan you can see easily the fracture of the posterior malleolus and you can detect the actual side of the fracture in these three patterns. And generally the posterior malleolus can be fixed according to its size using a screw and sometimes plates. Thank you.